Thank you.
It's I can't hear you. I just want to confirm. Do you see my screen?
Yes, I can see your screen. Can you hear that? Dr. Asler, are you still there?
Hello?
Hello. Can you hear me now?
Yeah. It was disconnected. I don't know why.
Okay,
But
a bit.
now it's back. So I'll
Okay.
start sharing my screen.
Yes, we could see it. So hopefully if you do that again, that will work perfectly.
Okay. Now, can you see my screen again?
Yes, that's good. Thank you.
Okay. And we can start the presentation, or we should wait to the students?
I think it's good to start. A few more people have just joined, so that should be good.
Okay. Well, basically, we are going to talk today about vascular trauma in wars, mainly in wars, because we know the situation now, and I'm sure that many people and many academics and clinicians are volunteering to help the Gazan people in this war, and we are trying to help in giving some glimpse about uh, vascular surgery and trauma. Hope this will help in taking care of our dear beloved patients. Well, first of all, I'm Dr. Ayman Alser. I'm a consultant vascular surgeon, and this is part of OxPal Trauma Series. Today, our objectives, we will talk in general about vascular injuries in wars, what's important about these uh, things in wars, what happens, and how frequent these cases, and what are the mechanisms of injuries. Um, Also, we are going to talk about, in general, if there is an arterial and injury, which is the was, and the topic that's called mangled extremity. And then we will be able at the end to know some principles and broad things about managements, not in specific, but in broad and a little bit helpful to our dear students and doctors. Well, those are some papers that may be beneficial in wars and to understand what's going on. Usually, papers are talking about vascular trauma. They are published at the end of any war. We have papers from Afghanistan in Gulf War, and we have also a lot of statistics about World War II. And unfortunately, we had higher risk of limb loss during these wars. At the beginning, the reported amputation rate was 60% of all combined injuries. And when there is an isolated arterial injury, the rate is 42%, which is still very high. So basically, the problem in these papers and what we have read about that there is a higher incidence of failed vascular repair as well. So this is another problem. That's not just a high rate of amputation, even the repair had higher rate of failure, like that paper talking in Vietnam War. The problem that still high rates of amputation still are reported in the modern era from arterial and skeletal extremity injuries. However, efforts are made in order to make the rates less and less. The problem is limb loss in most of our vascular trauma in wars. I'm not going to talk about death, but today basically what we are worried about is limb loss. And the most common cause is the delay in diagnosis and revascularization. The word delay can include many things. Delay in the diagnosis, the patient might come late because they are buried under the rubbles, they cannot be evacuated, the absence of ambulances, the absence of vascular surgery team in the hospital, the inability to evacuate people. All those are major causes that the medical facility cannot provide the best atmosphere like what's happening now in Gaza, actually. So the delay in diagnosis and revascularization is the main cause of limb loss during vascular trauma cases. Let's speak scientifically. What's happening when there is an injury to a vessel. We have either cut or laceration, which can lead to complete transection or partial transection. And we can clearly understand that the main thing will happen here is bleeding. However, sometimes in like traumatic amputation and full transection of the vessel goes into spasm and stops the bleeding by its own. Another pathology is called contusion, when there is an intimal injury and activation of the clotting factors, and then there will be thrombosis. And the problem here will be acute ischemia, because most of these vessels are healthy. Sometimes the intima and media goes into disruption, causing an aneurysm. And if there is a false hematoma inside the hematoma outside the vessel, we call it a pulsating hematoma if it's over an artery. And if it's neglected, it will cause the so-called pseudoaneurysm. Another pathology, if the trauma caused an tear, it opens into a vein. So there will be a communication between an artery and vein. This is called a fistula. And of course, the vessel might have external like fractures. We have two mechanisms of injury in vascular trauma, like blunt and penetrating. When we talk about wars, combat injuries of this type from military series usually are due to high velocity penetrating trauma. Actually, in most of wars, when they reported papers, vascular injuries are due to gunshot and blast injuries. So you can imagine, if you are following up one of the wars, if there is an airstrike, you can not see vascular trauma except if there's like a crush syndrome and people under falling down from heights. This what happens actually. But in a ground invasion, you will find a lot of vascular trauma because gunshot will be there. Also, traumatic amputation will be so much. So mechanism of injury is really attributed to the pattern of war. So when we speak, and this is a word which is important to our dear students, the word management. Management is not only treatment. Management means taking a broader idea about diagnosis and treatment as well. Speed is crucial. Vascular management is very important. Time is very important in vascular surgery. It's really important because you will save the life and you will save the limb. So we have rapid resuscitation. This is a main thing that we should put in mind. Like putting a protocol is very important in any hospital. So rapid resuscitation comes first. Like usual, we say primary survey or the ABCDE protocol comes first. So think like this, life comes before limb. And then you should have the ability to do a rapid scanning to your patient, which is called complete rapid evaluation, or sometimes we call the secondary survey to try to allocate where is the vascular problem, is it there or not? And then you should go, after detecting the problem, to an urgent treatment or definitive treatment. It's really important, the rapid resuscitation. The rapid resuscitation, it's the ABCDE, you should make sure that the airway is patent. When bleeding happens, so C comes first, so you should put some compression. You should take a sample of blood and put IV line and try to give fluids. I'm not going to go through the rapid resuscitation because our focus now is vascular trauma. However, it should be put in mind the other teams doing fast and taking care of hypothermia, because these can kill more than the vascular injury. So I advise everybody to learn about the guidelines of ATLS, Advanced Trauma Life Support. So initial treatment and evaluation should proceed simultaneously. And then you should control bleeding, replace volume loss. If there is a wound, cover it. Stopping the bleeding is easily by compression or pressing over the bleeding vessel. Do not try to repair in the AR, the resuscitation or clamps. Try just to cover and compress. Tourniquet is one of the ways to stop bleeding. However, compressing is important in mass casualty in order not to miss the tourniquet. And if you put it, you should write over the tourniquet, the TT, the tourniquet time. Reduce fractures and dislocation by splinting very rapidly. And it's very important to reevaluate people. If you put a tourniquet, you should look over and over again at your patient. If you left a patient with A, which is normal airway, should come back again. He might be suffocating because of the rubble and the other gas poisoning. So reevaluation is important in trauma. Some people might not have pulses at the moment of examination. After half an hour, when contusion happens, thrombosis occurs, and then you will have no pulse. So speed is important. We should have a high index of suspicion by doing physical examination, palpating the limb, and to palpate the vessels, the dorsalis, pedis, popliteal, femoral, and it should be bilateral. And you should look at the main blood pressure. If it's hypotensive, it's normal not to find pulses in the peripheries. So you should look at the pulses after resuscitation. If the P is fine, then look at the distal pulses. If they are not there and the pulse is 100 and the BP is 140, so there is a real problem there. If a unilateral pulse is felt and the other side is not there, so there is a real problem actually. The Doppler, which is the pocket Doppler, it's not very sensitive in trauma, however, it might help you. And then we have some other facilities like duplex ultrasound or angiography. And finally, of course, if all these things are not there, like what we are going to explain, we should go into exploration. So prompt diagnosis is very important. When we say suspicion of arterial trauma, this takes us into the two things that are very important, and this slide is extremely important, the hard signs and the soft signs. The word hard sign means there is a problem, there is an injury to a vessel. It needs operative intervention, or it needs exploration and to look with your eyes into the vessel, or to do some intervention endovascularly. However, when we say soft sign, this means there's a question mark about the problem. You need to do some investigations. You have some time. However, when we talk about hard signs, you don't have that much time. Please, if at any time one of my students have a question, please stop me and ask at any time. What are these hard signs? Active hemorrhage. No clearer sign like this. Active hemorrhage. And it should be active. It's not just oozing of blood. No, like fractures. No, it's an active, bright, like spurtle or oozing filling the field like venous injury. Large, expanding or pulsating hematoma, which means that there is a hematoma. And the word expanding means, or it gives an idea about the importance of re-evaluation. So it's increasing by time. This means that there is an active injury to the vessel. A patient coming with a gunshot to the neck, you should put your hand over the neck. You might feel some thrill, or you put your stethoscope, you will hear some bruit. So this means there is a fistula between carotid and jugular, for example. Feeling the limb, very importantly, to detect the 6 Ps of acute ischemia, like pallor, paresthesia, paralysis, pain, pulselessness, or coldness, or as we called it, poikilothermia. Soft signs are so many. Anything else can be a soft sign. Like if the people bringing the patient, carrying the attendants, carrying the patient, and they said there was a history of significant hemorrhage at the scene. So this is important that you should take in mind that he might be bleeding, maybe, or it's only just a fracture, or the people are talking about significant hemorrhage, but it's not. So it's a soft sign. If there's a nerve deficit, it might be taking a vessel as well, like fracture humerus can take the axillary nerve as well. Diminished pulses, or you are not sure about the pulses, this is a soft sign. Or proximity injury, like some certain fractures, like supracondylar fracture in kids might take the brachial into an injury, fracture hip of neck of femur might take the femoral, and so on. Or if the hematoma is small to moderate type, but it's not expanding. So hard signs, you should take care of these things. If you have this pocket Doppler less than 0.9, and we should know how to do the ankle brachial index. If it's less than 0.9, it had 95% sensitivity and 97% specificity for identification of arterial injuries. But it's not always accurate. So sometimes we use some better machine, which is the duplex ultrasound. With duplex, we know it means two. We know about the anatomy and the physiology of the vessel. We can see some images in the duplex ultrasound. So these are some images of duplex ultrasound, like we can see here, the yin-yang sign swirling the arterial flow going around an aneurysm over a vessel. So this is clearly can show you an injury, a pattern of injury. Angiography. Actually, angiography takes some time to do it. So there are two opinions of doing angiography. Do we need to take the patient to the cath lab and waste some time if he's in acute ischemia? But it has two important things. Excluding vascular injury, it's 100% sensitivity, and it might help you in planning the operation. But it's very important what's written in yellow. Angiography should not delay revascularization, and it's better intraoperatively. So make sure that it's unnecessarily in the presence of hard signs, unless you are and the site of vessel injury is unclear. So when you should do arteriography? If it's unclear location of the vascular injury, there's extensive soft tissue injury that you are unable to detect these hard signs. A major fracture dislocation, you want to make sure, especially like the knee dislocation. Knee dislocation, you should do a popliteal artery visualization through percutaneous angiography. Trajectory parallel to an artery. If there are multiple wounds and you want to make sure, shall I explore the femoral or popliteal or tibials? So angiography can give you a glimpse in order not to waste your time. Or peripheral vascular disease. If the patient is over 60, diabetic, hypertensive, he has an ulcer or amputated toe in the other limb, and now he came with a trauma, you should suspect that the vessel might be occluded due to PVD and not due to trauma. Here are some images of CT angiography. Like you can see here, there's a fracture and the TPT, tibio-peroneal trunk, is not visualized. It's important to do it operatively, intraoperatively, and not to open the elective cath lab to do these images, because as we have said at the beginning, time is crucial in vascular trauma. It's rapid, it's excellent to detect the injury. Here are some cases where we can see the contrast is cut off in the popliteal, in this case of major fracture, which shows that there is an injury in these cases. And here another image that shows a spasm or a non-occlusive intimal injury of the popliteal artery, which has been managed electively, and it has resumed later on with complete resolution. Here we can see clearly an aneurysm, as we call it a pseudoaneurysm if it's a trauma case, in the femoral artery. Here again, there is an occlusion with a collateral, which was a chronic ischemia rather than the occlusion caused by the trauma. So we finished the diagnosis. So how can we detect that there is a sure vascular injury? So what's the important in treatment is the speed. So the delay in repair will cause 75% of permanent functional disabilities, or unfortunately amputation. Non-operative management, actually, if management of minimal, non-inclusive, clinically asymptomatic, detected by arteriography remains controversial. Actually, some surgeons continue to insist that all detected arterial injuries should be repaired. However, this entity is very important in the pink pulseless hand of a supracondylar fracture in children, which sometimes or most of the time, if the hand is warm, pink, moving freely, we just ignore it and temporarily and follow it up daily, and this goes into a complete resolution later on. However, it's very important, if you are not going to operate in some cases, you should follow up your case. However, many vascular surgeons goes with definitive revascularization. There are methods of endovascular, like putting TVAR in transection of aorta, which is a covered stent in the transected vessel. Sometimes you treat active bleeding from non-critical arteries in a remote anatomical site. For example, GIT bleeding through cath lab, and internal iliac artery in a fractured pelvis through percutaneously taking the patient into the angio suite and coil the pelvic retroperitoneal bleeders. However, it's extremely important, if you are going to do endovascular management, the patient should be stable. And this is a very important question to my dear students. This is a case of pseudoaneurysm that treated successfully with a covered stent through a femoral approach with a local anesthesia. And this is, again, another bleeder treated with coils percutaneously. Usually we do endovascular in areas that it's difficult to access. So if we look at the body, the neck, arms, limbs are easily accessible. However, chest and abdomen, if they are not easily accessible, you can do that percutaneously. And again, do not do endovascular in unstable patient, except in specific situations. The operative management, which is open surgical protocol, remains the golden standard in trauma, especially in wars. You should do your incision over the vessel, do proximal and distal control. For my dear students, we are not going into operative details to do that. However, you should know the principles. The principles are proximal and distal control, and then remove the thrombi, and then you should do the heparinization, except if the patient is thoroughly bleeding or there are some other systemic causes of bleeding, like liver injury or splenic injury. In these cases, no need to do full heparinization. And then you repair either bilateral suture repair, end-to-end anastomosis, interposition graft, or sometimes bypass, extra-anatomical bypass graft. Those are not very important for my dear students to know. However, these are the main principles. So the open surgery remains the gold standards in vascular surgery in wars, especially. When we talk now, we have some topics which are very, very important to my dear students and doctors. If you have vascular injury and orthopedic injury, which of them you should do first? Is it a revascularization or the fracture fixation first? This is a very important question. And I don't know if we have students able to see and share their ideas. they can answer at any time. So who can answer this question? Which will you do first, revascularization or fracture fixation? Well, actually, in the past, initial fracture fixation seems logic because it looks funny that we vascular surgeons think that orthopedics are rough manipulators. And if I did a fan doing manipulation with their bones. However, prompt revascularization gives more positive impact on the outcome. Because if you left the patient unre so there will be substantial tissue damage, and you will start to look at deterioration of the clinical signs of ischemia, and hence higher rate of amputation. So this is a very important topic, especially in wars. You have many patients coming to you, more than 5, 6, 10 or more patients coming with vascular and orthopedic injuries. What will you do in these cases? And this is the importance of damage control surgery. And we have also in vascular a damage control vascular surgery. So definitive vascular repair should be avoided. Your important thing you should think of is revascularization. It should not be definitive, and hence the importance of doing intraluminal shunts. This is temporary shunt. You can bring a plastic tube beside you in the OT. There are some standard shunts, but in war, you can bring any plastic tube, cut it, put one of the proximal vessel, and then you have another tip in the distal, and then you can get a tube of plastic bringing blood from proximal to distal. You did not take the time of the orthopedic, and then you can let him do his job, and then you can come back and do your neatly, properly measured repair. Even the orthopedic, he can put some splint and leave the patient. So the importance of these temporary measures, which we call damage control surgery, comes when the patient is unstable, coagulopathic, acidotic, hypothermic, and the patient having other injuries in the abdomen and chest, and he has injury in the lower limb. You can, both of you, start doing the damage control surgery, because what will kill him is not the limb, but the other injuries. Or you both can kill him by doing a very prolonged surgery with bleeding and disturbing the hemodynamic and clotting factors and pH of the patient. This is an image showing the temporary arterial, and you can also use it for venous shunt. As we can see, the tubes are fixed with silk sutures. And here again, we have another image of arterial shunt, and also partial venous injury. Also, you can put a shunt inside. So the limb is revascularized, the tissues are red. Take the patient to the ICU, cover the wound even with saline soaked gauzes, and then come back when the patient is filled with good packed RBCs, fresh frozen plasma, not hypothermic. Other fatal injuries are dealt with, splenectomy or chest tubes, and then come back to do your repair in another better situation. So definitive repair and definitive fixation of skeletal extremity injuries should be performed, provided, if you are going to do the definitive full repair, if the patient is stable, there is clean wound, no contamination, availability of necessary time and resources, and you are not flooded with many patients coming to the ER at once, like what's happening in Gaza wars now. No other injuries requiring more urgent management. Okay, So I think now we can have an idea when to do definitive repair and when to do a temporary damage control repair. Because in both techniques, our aim is not to lose the limb. So do revascularization first, as we can see here. After putting here, we can see major fracture and the vessels, do the shunt, and then come back and correct the problem. And here, in this case, the fasciotomy was done prophylactically. And this is one of the important things which we do a lot in wars, fasciotomy. So which will we do? A fracture first or revascularization first? Someone will come and ask, how can we do revascularization in this image? There is disturbance of bones, and I cannot do even the shunt. In this case, you can agree with the orthopedic to put only 2 pins and a rod, and then you can do your job, and then he can continue the other external fixator rods and screws and wires and the rods. So it should be a shared decision. For example, if a case came with bleeding, of course, you should put your clamps, and if the limb is not in ischemia, tell him put only 2 rods, and then you put your shunt, and then he should continue the complete X-fix. Specific rule, which will we do in a specific order. However, as I said, an unstable patient, do damage control, both of you, and then come back. If the patient is stable, both of you, you can do the definitive repair. Here, we can see a popliteal artery injury that has been treated with a definitive arterial repair by shunt. We can see the shunt here. It's looped like that, or you can do it straight, whatever. And then the patient is having his limb survived. So, as we have agreed, the consensus is to do revascularization first. Let's talk about other measures like on-table arteriography. It's really important to do completion arteriography, which is at the end. Completion means at the end of your job, to make sure to check the patency of the repair. If there is some technical error, you can do it. Intraoperatively, you can check if showering of clots occurred in the distal vessels. So you can open one of the stitches, put a Fogarty, and pull out or thrombect these clots. So it's really important. Another auxiliary important thing to vascular injuries is the fasciotomy. Fasciotomy, we do it liberally in many cases because these cases coming with a compartment syndrome. So you should have a high risk of suspecting compartment syndrome following reperfusion. Most of the cases coming to us is in damaged fascia and muscle, so they are already fasciotomized. Occupy you should make sure that the fascias are open, so you will not have a bad compartment syndrome, which will occlude your vessels again. Sometimes if there is contamination and sepsis because of the field of injury, we do extra anatomical bypass. So if the popliteal fossa has an injury with soiling, sand, contamination, dead muscles, you can do femoro-popliteal or femoro-anterotibial with a side vein going anteriorly, temporarily, and you can later on do a positive, definitive anatomical repair when the contamination goes away. So avoid unnecessarily surgery for non-occlusive arterial lesions, as we have said at the beginning. Okay, another issue which is very, very important, when we can see these images these days in the wars and especially in Gaza, a lot of amputee. So is it wise to amputate or to repair? This is a question which is very, very important in our field. And this takes us to the important title called the mangle limb. So in this image, shall we amputate? Shall we repair? What shall we do in these cases? It's important to save the limb. However, it's more important to save the life of the patient. This is a real image from Gaza, and you can detect the much pain in this patient looking at his mangled right limb. So, if we are going to talk about the mangled limb, we should define what is mangled limb syndrome. And the mangled extremity happens mostly in these 20 to 40 years, lower limb more than upper limbs. We will talk also about upper limb. So mangled limb, if there is 3 to 4 systems have been injured: soft tissue, bone, nerves, and the blood or the blood supply. So these are images of mangled limb. Some limbs are only fixed by piece of skin, some only by one bone, and other totally disrupted like this guy. It happens also in upper limbs as well, mangled limb syndrome. There is some classification the orthopedics are more aware about, called the Castillo-Anderson classification of open fracture. However, the more important in open fracture for us are these two at the end, which are the 3B and 3C, where there is significant soft tissue loss and exposed bone that requires soft tissue transfer, or associated vascular injuries that requires repair for limb preservation. So when we talk about mangled limb, we are talking about major open fractures with soft tissue, nerves, bones, and etc. And of course, there are lots of mechanisms of injury in mangled limb, like motor vehicle accident, but in war, they happens in high velocity gunshot, blast injuries, explosions. So those can cause these things. Again and again, the initial management should be ATLS protocol. Make rapid resuscitation and then do coverage of bleeders, wash with saline, give tetanus toxoid, and give antibiotics, and then move to the OT. So field dressing should be removed and any significant bleeding immediately controlled with direct pressure in the OR, or putting tourniquet, compressive dressing, and then you should think again, what shall we do? Life over limb. So a patient coming with, there are many, many scenarios in this case. A patient is coming with major brain injury, chest hemothorax, retroperitoneal hematoma, severely hypotensive and acidotic with mangled limb. Here, the limb comes at the end of the priority. And in these cases, amputation might be more important than wasting not your time, but the patient time, and you might get him into mortality if you go with a repair. However, you should, before taking the decision, you should look at the patient clearly by evaluating the limb, neurologically, vascularly. The wound should be assessed in the ER and covered and then treated in the OR. Wound dressing, the gross alignment and splitting should be performed temporarily. So untwisting the limb, which is mangled, is very important because sometimes the vessel is intact. However, the mangled limb is occluding the vessel because it's just twisted. Exploring the ward in emergency room is not advantageous. You should cover with saline and then go to the OR. So any radiographic studies must be obtained. So if like ultrasound to the abdomen, these things, and give intravenous antibiotic like what we have said, tetanus toxoid, tetanus prophylaxis. And then you should take, which is very, very important, photographs. It's very important medico-legally, because if the plastic surgeon will come and look, and then the orthopedic, and then the vascular, everybody is exposing and covering, exposing and covering. This is waste of time and introducing more trouble to the patient. So take photographs and show it to the others. And all the teams should take the decision inside a sterile room. However, again, we did not answer the question, shall we amputate or salvage? This is why they put many scores, like called scoring system, to answer this question. What we have, this is very important. In the intraoperatively, you should think of, again, to put some shunt if the patient is going to salvage. because the warm ischemia time should not exceed 6 hours for lower extremity and 8 hours for the upper extremity. Again, we did not answer the question. Shall we amputate or do a definitive repair or salvage to the patient? Again, I'm not going to answer it now. First surgery is critical to the final outcome for the mangled limb. Your goal is to remove the devitalized tissue, removal of contamination, restore good vascularity, hemostasis, and achieving bone stabilization, and then the other tissues. So this is the main goal, which is the salvage, which we think is the better. So now you have 4 scenarios. Either to do immediate or primary amputation. This is called at the beginning. So you don't give any attempt of salvage. Or you do salvage, which is successful, repair the arteries, the bone, everything. Or you do the salvage, and after a few days, unfortunately, a problem happens and you do secondary amputation, unfortunately. Or the salvage is unsuccessful with late amputation after the first hospitalization. The patient will come with infection, for example, sepsis, and then you will unfortunately do amputation. So we have 3 amputations and 1 successful salvage. So again, what will we do? Limb salvage versus amputation. Actually, if preserving a mangled limb is a technical possibility, the question is often raised whether the end result will be functional or not. This is very important. So you have 2 questions you should ask yourself. Is the salvage feasible? You can do it. The resources are there. The OT is empty. No many cases around. Or is it advisable or not? So you can take a lot of time doing a case with severely mangled limb, and at the end, you end up with amputation. However, again, shall I do amputation? The amputation is a devastating event in a person's life. The consensus should be taken by many people. Actually, in some hospitals, the decision should be taken by 2 consultants or more, orthopedic, vascular trauma, plastic surgeon. And you should take the decision shared with the patient himself and his family. Some other specialties like psychologist, nursing, and most importantly, the patient and family and rehabilitation specialists should be included in this decision. A patient with complete traumatic disruption, with clearly irreparable injuries and immediate completion amputation should be performed. Although the decision to amputate in the acute setting is difficult for the patient, family, and the treating surgical team. The alternative of prolonged unsuccessful attempts at limb salvage will subject the patient to great physical, psychological, financial, and social suffering. So you should think a young adult male, you should go with salvage more than an 80-year-old with a vascular injury. The patient who's active in his life, you should go with salvage. However, that's not enough to take the decision. Let's take the clear image. If indication for primary amputation, if there's a complete anatomical disruption in the tibial nerve, in addition with prolonged limb ischemia, or if there's severe soft tissue loss that cannot be reconstructed, you look at the tissue like in this middle, the muscles are completely dead, so there's massive contamination. Or the patient is extremely unstable with bleeding from this amputation that if you do amputation, you might save his life. Or if the foot is totally lost, what's the importance of reconnecting a dead foot to the patient? You should think of the lethal triad, coagulopathy, hypothermia, and acidosis. A patient with massive blood transfusion, you should go with amputation. Systolic blood pressure less than 90 for more than 1 hour is hypotensive. Do not waste the patient time in doing a lengthy salvage, because mangled limb is not like what we talked at the beginning of the lecture. Mangled limb is a lengthy procedure of salvage. Okay, if I'm gonna amputate, where shall I amputate? In lower limbs, below knee, through knee, or above the knee? but you should go through a clearly should not go through a non-viable tissue. A thorough irrigation, debridement should be done. It's not important to close the wound at the beginning because of a lot of infection. You can do some temporary dressing like VAC, which is a negative pressure wound therapy, in PWT or VAC dressing, or you can put some gauzes and then come back and close the wound again. This is the VAC, and this is the amputation. Okay. The problem that the cases will not come in a clear amputation decision. Most of the cases come in the gray zone. So there are a lot of factors, as we have said: the patient age, the previous health status, the presence of concomitant organ injuries. This is very important to take the decision. However, if you are in the